3 weeks into block one, I think. And so that's pretty exciting too. And I start on service actually on Monday for 2 weeks on the Harborview MICU. So I will be seeing a lot of you then. So this morning, the topic is what to do when you're called to see someone who's short of breath, someone with dyspnea. And sort of, I want to cover a little bit about the mechanisms and then your bedside evaluation and some emergency care for people who are acutely short of breath. That's what I want to cover today. Dyspnea is nothing more than an abnormal or uncomfortable sensation of breathing. It's very subjective, a subjective experience of discomfort that when you really start talking to folks, it's comprised of a lot of different sensations that vary in intensity. And so again, it's really hard to sort of accurately describe it any more than that. And in fact, you will see folks, all of these patients, a type 1 diabetic with nausea and vomiting, a man with an acute GI bleed, chronic liver failure with ascites, a woman with CHF, pneumonia, bad diarrhea, PE, all of these things cause dyspnea. Isn't that crazy? Things in all different organ systems cause dyspnea. And the reason is that the respiratory system is designed to maintain homeostasis with respect to gas exchange and acid-base status with the least amount of work possible. So maintaining homeostasis, gas exchange, and acid base, and any derangements in this balance or in the work required to maintain homeostasis results in dyspnea. So if homeostasis is out of whack, or if it's requiring more work to maintain that homeostasis, so to speak, normals, numbers, then people will sense shortness of breath. And the components then of the respiratory system in terms of maintaining that homeostasis are everything from the brain to the spinal cord to the nerves, the muscles, chest wall, diaphragm, pleura, and then, gets to the lungs, the airways, the alveoli, heart, blood vessels, blood, and even all the way down to the mitochondria. And any derangement in any of that can throw things out of whack and lead to shortness of breath. So again, this is why this is a huge topic, so to speak. And what I really want to spend time doing is giving you a framework with which to approach patients who are presenting with acute shortness of breath. So pathophysiology then, based on all of what I just talked about, increased central drive to breathe in the brain, increased central drive, and that can be due to disease, to medications, even just to sort of psychogenic causes of hyperventilation. That will lead to a sensation of dyspnea. Excess respiratory muscle work, so something we refer to as the work of breathing. If it takes more effort to expand the lungs, expand the chest wall, that's perceived as shortness of breath. Poor airflow and lack of lung stretch leads to shortness of breath. And then all of the gas exchange and metabolic demand issues can cause shortness of breath. Hypoxemia, tissue hypoxia, hypercapnia, metabolic acidosis, all these things can lead to dyspnea. And in fact, many clinical conditions have more than one mechanism at play. So let's dive into If everyone could mute, that would be awesome. Thank you. So let's dive into a first case and start talking about an approach to dyspnea. So you're on night medicine. Nurse calls you at 2:30 in the morning to report that Miss Petunia Kalo, a 68-year-old woman, admitted 5 days ago for community-acquired pneumonia and a mild COPD flare, now has worsening dyspnea. She's complaining of worsening shortness of breath. And the nurse asks you, what would you like to do? So you dutifully check your sign out. And here's a summary of the sign out. Here's her name, 68 years old. She's full code, no known drug allergies, hospital day 5 from pneumonia, COPD flare. She's been stable. She has a past medical history of mitral stenosis, coronary disease, has had an NSTEMI in the past, has some heart failure, COPD, history of DVT, osteoarthritis. Here are all the medications she's on. And your sign out is actually that she's getting better. Her white count's improving, her blood cultures are negative, and really sputum cultures were non-specific. She did have a right subclavian line placed today, but really nothing to do. She should be fine overnight. That's your sign out. So you're looking at this and you're going, holy moly, all these things could be going on. She just had a right subclavian line. She's getting fluids and IV antibiotics, a history of DVT, heart failure. And you're thinking, okay, this could be a COPD exacerbation. Maybe her pneumonia is getting worse. Maybe she's developing ARDS. Maybe she has a pneumothorax from that right subclavian line. Maybe she's developing pulmonary edema. She has mitral stenosis and heart failure, and she's been getting IV fluids and antibiotics. Maybe she's had a PE because she's been at bed rest for 5 days. So all this stuff is swirling through your mind. My first question, and I'm not going to do this as a poll, I just want you to either shout things out or put them in the chat. And Emily, or can you monitor that? You're monitoring the chat. So what would you do next? Would you give furosemide, 40 milligrams IV times 1? Would you order a CT angiogram? Would you go see her? Would you stop her IV fluids? Would you activate the cath lab? Or would you grab the ultrasound and do a bedside POCUS? I see the chat numbers going up. What are people throwing in there? Maybe I can open it. I wonder if I can open it.
There is a lot of go see hers. That's, I think, number 1, 2, 3, and 4 going on. Go see her. And then Joanna wants some vitals before seeing her.
Fantastic. I love that. Yeah, the only right answer right now is to go see her. You have to go see her. And that's what you do. So when called about dyspnea, and the vitals are exactly right, you guys are, look at you, the end of the first block R1s. When called about dyspnea, the key first steps on the phone, ask for vital signs. Okay, they're short of breath, but what are their vital signs? What's their oxygen saturation? It's really helpful to know their mental status and a little bit of extra background. Did something just happen? And then think, prior to your arrival, do you want her on oxygen, a monitor? Does she have an IV? Do you want to give her an empiric albuterol? Might you get a blood gas and cardiogram or chest X-ray, etc.? But you have to go see her. Okay, so you go run and see her, and she's in moderate respiratory distress. She's afebrile, 37.4, heart rate's 108, she's a little tachycardic, blood pressure's okay, 128/67, respiratory rate is a little high at 24, and her SAT is 91% on 4 liters nasal cannula. She's already on oxygen. No JVD. Her lungs have some crackles in the right base, an occasional soft wheeze, but good airflow. Pretibial edema bilaterally, although a little more on the right than the left. What do you want to order next? Throw a couple of things in the chat. Oh, I wonder if I'm going to try to. Got too much going on. I can't see the chat. What's the next step?
We have a Brave chest x-ray.
Yay! That's right. You're going to get a chest x-ray. Now, here's one little weird tip about the chest x-ray. One of my best friends is a chest radiologist, and he gets really annoyed when we order the chest x-ray as FU. He somehow takes it personally. And then, yeah, do laughing. And then worse, FU SOB. So anyway, sorry, a little goofy humor first thing in the morning. My coffee's still kicking in. But yes, you want to get a chest x-ray. The chest x-ray shows that her right lower lobe focal opacity, her pneumonia, is unchanged from admission. There's no evidence of worsening heart failure and no pneumothorax from that central line. Here you get a blood gas, 748, pH 748, PCO2 34, PO2 62 on 4 liters nasal cannula. Baseline was 2 liters nasal cannula, 739, 43, 78. So she's blowing down her CO2 a little bit, and she's a little bit more hypoxemic. Her cardiogram, no ST T wave changes, no ischemic changes, no changes from baseline. So now you're like, okay, what next? And before we get to the what next, I want to introduce you to what I call the 3 pillars of care for patients with shortness of breath, with acute shortness of breath. The first 2 we've already done. The first pillar is get your safety net in place, okay? Protect the patient, get them on oxygen, get IV access if they don't have it already, and put them on a monitor so you can follow what's happening and monitor, maybe a cardiac monitor, but may also be a pulse oximeter. Then, as was already called out, vital signs, pulse, blood pressure, respiratory rate, temp, saturation, and mental status. I view mental status as a really important vital sign for people with respiratory difficulties. And then you want to do your dyspnea survey, which I'll introduce in a minute, ABCDE, and that will take you through an approach to figuring out what might be going on. So 3 pillars of care: safety net, vital signs, and then your dyspnea survey. Now, the dyspnea survey is a little bit of an anatomic approach. Some people think more physiologically, and that's totally legitimate too. So these are physiologic buckets of shortness of breath, decreased oxygen delivery to the tissues that can happen with hypoxemia, decreased cardiac output, or relative or absolute anemia, or increased CO2 production from metabolic acidosis, fever, hypermetabolic states like hyperthyroidism, thyroid storm, decreased CO2 clearance from dead space, from a PE or air trapping or airflow obstruction, and then work of breathing, respiratory mechanics being impaired with neuromuscular deficits, decreased lung compliance, stiffer lungs, diaphragm impairment. These are physiologic buckets, but I like this more anatomical ABCDE because it's sort of, you think through that ladder. A is for airway. Do they have any upper airway obstruction, which sometimes happens? B is breathing or lung problems, and that's a big bucket: asthma, atelectasis, COPD, effusion, pneumonia. Those are things that are happening in the lung. So airway, lung. C is circulation. So thinking of the heart and blood, anemia, heart failure, arrhythmias, shock, pulmonary embolism, things that impair circulation. D is deficits, not awesome, but those are neuro and musculoskeletal deficits. So muscular weakness, someone with myasthenia gravis having a flare, etc. And then E is the electrolytes. So acidosis, sepsis, things like that, electrolyte abnormalities. So A, B, C, D, E. And using this pillar, A, B, C, D, E, we've got a couple of things in this woman that you're already thinking about. Maybe her COPD is worse, she's got a little bit of soft wheezing, pneumonia, pneumothorax. Those have been partially ruled out by the chest x-ray. Heart failure, ischemia, PE. Didn't look like she had much worsening heart failure on her chest x-ray, and her ECG didn't show any acute ischemia. So what would you do next? And this is the first poll for you guys. What would you do now? Would you calculate a pretest probability of PE, order a BNP, order a D-dimer, order a CT pulmonary angiogram, a VQ scan, or an echocardiogram? Go ahead and let me know what you're thinking now. I guess I can answer, can't I? I should throw it.
We're getting answers trickling in. We're
Okay.
at 33 people, so we'll give just a moment more.
Okay, pretest probability of PE or a CT pulmonary angiogram. So clearly, if you combine those, most of you are thinking about pulmonary embolism. A couple of you wanted an echo, one or two wanted a D-dimer, also thinking about venous thromboembolism. So that's awesome. And quite honestly, you're heading in the right direction. I want to introduce some of the clinical prediction models, because I think that's the next step. There are several in the literature. They're on your phones, and you can. I don't know. There must be 3 or 4 or 5 of them out there right now. I don't really think one is any better than the other. The Wells clinical prediction model was one of the very first ones that was introduced and is a validated model. Looks at clinical signs and symptoms of DVT, gives 3 points. An alternative diagnosis less likely, 3 points. Tachycardia, immobilization, previous venous thromboembolism, hemoptysis, malignancy, and then gives the points at the bottom. And this woman she has some asymmetric lower extremity edema. This one is always confusing to me in the Wells model. It's kind of subjective. Alternative diagnosis less likely than PE. That's what I'm using the model for. So why are you asking me that? But she may get points for that. She is tachycardic. She has been immobilized for 5 days with her hospitalization. She's had a previous she's had a previous DVT. So she actually gets 7.5 points. And so is at high risk for the pretest probability. I'll just show you another score, the revised Geneva score, published in the Annals of Internal Medicine, also validated. This one is less subjective. They don't ask you, do you think something else is going on? And She has all these criteria, and so therefore has a score of 13. So in using the Geneva model, she also is high risk, has a high pretest probability of venous of PE. Sorry, and so either one, I think, again, it doesn't really matter. D-dimer, which we get a lot in people presenting to the emergency room, is best used when your clinical suspicion is low. If you have a low pretest probability and a negative D-dimer, you don't need to do anything more. But she has a high pretest probability, and so a D-dimer is not going to sway you very much. A positive test is not diagnostic, especially as I think you know, in inpatients who have inflammation for various things, and that can elevate your D-dimer. So that's why I wouldn't get a D-dimer in this case. One, she's high pretest probability, so a negative D-dimer is not going to stop me. And then she's also been hospitalized for several days, and so it's likely to have a false positive D-dimer. Now, the other reason to do clinical scoring is that CT pulmonary angiogram, which, by the way, has just exploded as one of the most common tests that we're getting in the hospital nowadays, even for people with low pretest probability. But CT pulmonary angiograms are not 100%. People think of them as the gold standard. And in this study from a number of years ago, the PIOPED-2 study showed that you had to combine your pretest probability with the CT angiogram findings to best diagnose your patient. And the most important boxes here are this one. If you have a high pretest probability and your CT angiogram is negative, in this study, there was still a 39% chance that you actually had a PE. And that was based on invasive pulmonary angiography. That was the gold standard there. And on the other side of the coin, if you had a low pretest probability and you had a positive CT, there was only a 38% chance that it was a true positive. So it's really important to combine your pretest probability with your CT angiogram to know what the next step is. And I think that people, including radiologists, have forgotten some of these data. So that's why I'm encouraging you to still use your phone and calculate a pretest probability. Well, here's this woman's CT angiogram, and you can see the very large right and left-sided pulmonary emboli. She had a radiographically large PE, although she didn't fall into the category of massive pulmonary angiogram. So case number one, pulmonary embolism in the middle of the night. You guys worked it up and diagnosed her perfectly, and were suspicious of the PE. So to summarize, diagnostic strategy for venous thromboembolism: determine your pretest probability. Use one of the scores: Wells, Geneva, PISA, PERC, Padua. There's a number of them in the literature. I think they're all good. They're all validated. Do basic studies, an ECG, a chest X-ray, a blood gas. D-dimer, not helpful for inpatients. Use a diagnostic algorithm. And then VQ scan versus lower extremity duplex. We do those much less frequently. There's still reasonable studies to do if you are working at a place that you can't get a CTPA in the middle of the night, et cetera. And then always ask yourself, based on the pretest probability, should you start therapy before waiting for that 2 hours for the diagnostic test? And in people with high pretest probability and with a low risk of bleeding, the answer is yes, you should start therapy even before getting the CTPA. Okay, case number 2. You're again the night medicine intern. Nurse calls you at 3:30 in the morning, so an hour later, to report that Mr. William Power, 65-year-old man, admitted earlier today for anemia of unclear etiology and COPD, has worsening shortness of breath. Nurse asks you what you would like to do. Here's your sign out. Mr. Power, 65 years old, full code, no known allergies. He's admitted for a bad anemia and a mild COPD flare. His crit was 22. He's got gold stage 3 COPD on prednisone, albuterol, and ipratropium. He's on sub-Q heparin. His anemia workup is ongoing, but it doesn't appear to be a GI source. Again, you were signed out, nothing to do overnight. And so as you're thinking about this, you're doing your ABCDs and his airway seems clear. Could this be worsening COPD, pneumonia? Did he aspirate? Is his anemia getting worse? Developing heart failure, ACS, sepsis? What would you do next? Nope, not yet, Emily. So what would you do next? Order Lasix, transfuse him 2 units, order a Coombs test, activate the cath lab, go see him. You go see him. Right, so we're going to do that. So you go see him. He's an older gentleman. He looks ill. He's a bit overweight. He's alert and oriented ×3. Again, a little tachycardic, a little hypertensive, 160/105, respiratory rate 22, 38.1, SATs 89% on room air. He looks like he's in respiratory distress, diaphoretic, wheezes, rhonchi, scattered crackles, prolonged expiratory phase, no JVD, distant heart sounds, no peripheral edema. And so now, Emily, what would you not order for him next, everybody? What would you not do? Would you not put him on oxygen, not get a chest x-ray, not repeat his crit, not get a blood gas, or not do peak flow or bedside spirometry? How we doing? Awesome. Cool. Yeah, the majority of you said you wouldn't do bedside spirometry, and then a smattering of a few other things. And that's right. We do peak flow measurements in people with asthma, especially kids, but bedside spirometry doesn't have much of a benefit in acute airflow obstruction. So let me give you some of the other data. Here's his blood gas, 729, 54, 58. So acute respiratory acidosis with hypoxemia. You do repeat his crit, it's 21%, it was 22 on admission. So his anemia is not getting worse. Chest x-ray, no new opacities or edema. Doesn't look like he's in heart failure. No new pneumonia or aspiration. Does have hyperinflation, and he is. So you would put him probably on oxygen. So what do you think's going on with this guy? Just someone throw something in the chat or out loud. What do you think is causing his shortness of breath? Someone say something. Oh, one thing showed up in the chat.
Nicole is thinking about infection or sepsis,
Good.
COPDs being mentioned by a couple of people.
Fantastic.
Lucia would like an EKG.
Oh, as another study. Yeah, that's actually, you're right. I didn't show you his ECG. For him, his ECG just showed sinus tachycardia and no acute changes. And people are thinking along the same lines. And this is a COPD exacerbation with hyperinflation and prolonged exhalation on physical exam, CO2 retention, hypoxemia. And so, again, I'm not going to go into details about managing an acute COPD exacerbation, but these are some of the standards: oxygen, inhaled short-acting bronchodilators, corticosteroids, and for non-ICU patients, 40 milligrams of prednisone daily for 5 days. Limited spectrum antibiotics like a macrolide have been shown to make a difference. Diuretics are always helpful. Dry lungs are happy lungs. Those of you in the ICU, when we start working together, know that's one of my mantras. And then non-invasive ventilation can be very helpful, and we'll talk more about how to do that. And then intubation and mechanical ventilation. But usually bedside spirometry is not very helpful. A blood gas usually is needed. And most of the time, if someone doesn't have one already, an arterial blood gas is better. But a venous blood gas can be used to track venous CO2. You just can't use it to measure oxygenation. And then a chest X-ray and an ECG are usually needed, and those are some of your main differentials. And for oxygen saturation goals, again, I know most of you know this, but for most patients with hypoxemia, just keeping the SAT 90 to 94, or so you'll see some people 88 to 92. That's all okay. You don't need to drive their SAT up higher than that. If they also have severe anemia, you might want to keep the SAT higher, and there's some evidence for that. Again, with patients with COPD, ask what's their baseline. Too much oxygen and too little oxygen can be bad. But again, I don't want to focus too much on the specifics of management so much as making the urgent assessment. So let's go on to case number 3. An older man now, 82 years old, has a history of dementia, and he's admitted with fever, a decube on his sacrum. He's getting wound care. He's on pip/tazo for antibiotics. He's getting enteral nutrition, and you're called to see him for shortness of breath. So think for a second about what could be going on in this older man with dementia, now febrile, getting antibiotics, getting enteral nutrition. And these are probably some of the things you're thinking about. Maybe he mucus plugged, or maybe he aspirated and or has developed a nosocomial pneumonia. Maybe he's volume overloaded. Maybe he had a PE, just like the first lady. Maybe he's been working hard to breathe and his respiratory muscles are getting tired. Maybe he's septic. Maybe he's on enteral nutrition. Maybe he's getting fed too many calories and is a little feeling short of breath from that. So that's what you're thinking with your survey. And then, so on exam, he's somnolent, but he's awake. He's in moderate respiratory distress. He's febrile, 38.8, heart rate's 110, a little bit soft on his blood pressure, 95/67. 38 is his respiratory rate. He's saturating well on 4 liters, no JVD. He's got a few bibasilar rhonchi, but really no crackles, no wheezes. Bilateral trace pitting edema that's kind of symmetric. Okay. So here's the data that you start collecting. His chest X-ray is clear. It shows low lung volumes, but it's clear. So no big aspiration, no big pneumonia. His cardiogram sinus tach, no ischemic changes, no changes from baseline. So what next? What data would you like next? Someone, who wants a blood gas? Ab, do you want a blood gas? Yeah, okay, awesome. Sorry, I didn't mean to call you out, but you're the only person I can see right now on my screen. So you get a blood gas, 747, 25, so respiratory alkalosis, PO2 89. Respiratory alkalosis, that's interesting. Let's get a BMP. So you do that, and here's your BMP. Sodium's 144, 3.2, 106, 18, 38, 1.7, 168. What do you see that's going on? Put all these numbers together. What do you see that's going on? I hope what you see that's going on is that there is a primary respiratory alkalosis, but he's got an anion gap of 20. So this is a mixed metabolic disorder with an anion gap metabolic acidosis and primary respiratory alkalosis. What's going on with this guy? What do you think?
We had a couple of people voting for sepsis with an elevated lactate.
Awesome.
And maybe an aspirin intoxication question mark was another.
Yeah, that's brilliant. And yes, an aspirin intoxication would cause this, this pattern. But you ask the nurse and he hasn't been getting any aspirin, and sepsis is exactly right. And the reason that we all know about the anion gap metabolic acidosis that comes with sepsis and septic shock, primarily from a lactic acidosis. But people forget about the primary respiratory alkalosis. And early in sepsis, you can get a primary respiratory alkalosis. The early cytokines of sepsis, the interleukins and TNF, they actually have a direct effect on the brain. So he's hyperventilating not just to correct for the anion gap metabolic acidosis, but over and above that, because again of the circulating cytokines that have a direct effect on the respiratory center. So don't be confused. Sometimes early sepsis and shortness of breath presents just with the respiratory alkalosis before the acidosis kicks in. Awesome, you guys. Great. And I think we have time for one more case, which is a fun one. This is a real, actually, these are all real cases, but this was a case that I was involved with. You're on long call, which we don't have too much of anymore, but you're on long call and you get paged to the ED at like 2 minutes before the cutoff, 10:58 p.m. to admit Christy Leeds, a 37-year-old woman with a history of lupus and Evans syndrome. Evans syndrome is an autoimmune hemolytic anemia and an autoimmune thrombocytopenia. That combination is referred to as Evans syndrome. So you can see she's got a lot of autoimmune disease, lupus and autoimmune hemolytic anemia, autoimmune thrombocytopenia. She's had recent flares of her autoimmune hemolytic anemia requiring aggressive immunosuppression. She's on MMF, Cytoxan, Rituxan, she's getting steroids, and her baseline hematocrit hovers around 18 to 21%. She came in with severe progressive dyspnea on exertion associated with chest heaviness and lightheadedness, and you're called to the ED. And of course, you're thinking her anemia is out of control, but her hematocrit is 19%. It's at baseline for her, and you're called to admit her. Again, she's on MMF, prednisone, dapsone, and folate. She's awake and alert. She has slightly increased work of breathing. She's afebrile. She's tachycardic at 106. Her blood pressure is 130 over 84. So blood pressure stable. Respiratory rate's 20, a little bit high. Her saturation is 89 to 91% on variably 2 to 5 liters of nasal cannula. The ER has been titrating that up and down a little bit, but her sats are just, they're not awful, but they're just hovering there around 90. No JVD. Her lungs are clear. She's got a systolic ejection murmur, but no gallop, no crackles in her lungs. I said that. No cyanosis or edema. All right, you order some initial data. Her chest x-ray is clear. Her cardiogram, sinus tach, no acute changes. Her hematocrit is 19%. And her blood gas, her arterial blood gas, 737, 31, 92. So her PCO2 is a little low. Her pH is normal. And her PO2 is 92, although her SAT, remember, was 90%. And here's her BMP, 138, 3.5, 102, 18, 4.6, and 85, with an anion gap of 18. So let me put that together for you. She's got an anion gap metabolic acidosis with respiratory compensation. She doesn't have a primary respiratory alkalosis. She's got respiratory compensation, and then and without hypoxemia. And then what next? So this is our last poll question. What would you do for Christy now on admission? Would you get a CT pulmonary angiogram? Would you empirically transfuse her 2 units of packed cells? Intubate her for impending hypoxemic respiratory failure, get a repeat blood gas with co-oximetry, order blood cultures and broad spectrum antibiotics.
This one is good. There's a mix. There's a mix of answers coming in.
Awesome. This was a fantastic case, actually. It had a good outcome. Don't worry, everybody.
Okay.
Awesome. So a couple of people said, I don't trust that initial crit. She's got hemolytic anemia. I'm just going to give her 2 units of packed cells. No one's thinking PE. Intubate for impending hypoxemic respiratory failure. Yeah, she looked like she was working hard to breathe. And her PO2 was 92, I think I said, but her SATs were low and requiring oxygen. Get co-oximetry, about a third of you, and blood cultures and broad spectrum antibiotics. Not wrong while you're trying to figure things out. She's a woman who's clearly immunocompromised. Absolutely. So good. So let's get some more data. So you get the blood gas with co-oximetry, and lo and behold, her met hemoglobin level was almost 20%. Anybody catch why her met hemoglobin was high? Anybody catch that in her history?
There's some votes for dapsone or medication effect.
Absolutely. She was on dapsone as prevention for PJP because of all of her steroids and immunosuppression. And she developed a dapsone-induced met hemoglobinemia. And so met hemoglobin causes a relative anemia. Her hematocrit was unchanged from baseline, but 20% of that hematocrit was tied up as methemoglobin and couldn't carry oxygen to the tissues. So she, and by not being able to deliver oxygen to the tissues, it created a lactic acidosis. So it was as if her hematocrit was 20% lower than what it already was. So she got treated with methylene blue. 50 milligrams IV was given. She actually required a second dose about 12 hours later, and the dapsone was discontinued, and she got better over the next 2 or 3 days. And her dyspnea was all due to relative anemia from methemoglobinemia, so which only got figured out by sending the co-oximetry panel. And the tip off there is the difference between the PaO2, the partial pressure of oxygen dissolved in blood, and the saturation of hemoglobin on the pulse oximeter. And that often can be a clue for an abnormal hemoglobin. So awesome. So, so as we wrap up, we all think about the heart and lungs with shortness of breath, but don't forget about the non-pulmonary causes: metabolic acidosis, sepsis, relative and absolute anemia. Ascites, massive ascites will impair the diaphragm and people will feel short of breath, neuromuscular disease, anxiety, etc. And so what I've covered for you today, the mechanisms of dyspnea, some initial bedside evaluation and some initial emergency care, presented you with the 3 pillars. Think about your safety net, get your safety net in place, get vital signs, and then do your dyspnea survey, A, B, C, D, E, which will then take you through this differential: airway, breathing, circulation deficits, electrolytes, and other. And that should help you in your initial assessment of patients with acute dyspnea, as we've talked about in all of the cases today. So with that, thank you very much for coming this morning and for your attention and for participating with the chat and the survey. I really appreciate it. And these folks are also short of breath, but they're at high altitude. So, so anyway, all right, everybody. Thanks. I can stay for a few minutes if people have questions, but I'll stop sharing my slides.
Thank you so much. Yeah, any questions, please feel free to ask. We're getting a lot of thank yous, Ken, in the chat.
Oh, that's awesome. Thanks, everybody. I see the clapping hands. I love those. So. There's the, yeah, now I see all the chat answers.